So if there's anything I say that you don't understand, please stop me. You can wave like this, and I'll know that I've said something you don't understand. So these are my disclosures, but none have anything to do with what I'm going to discuss today. So, oh, okay, it doesn't show as well as I thought. So so what is dystonia? So our definition as physician and researcher is an hyperkinetic movement disorder that's characterized by sustained muscle contraction, frequently causing twisting and repetitive movements or abnormal postures. Okay, so basically what hyperkinetic mean is too much movement. Okay, and then sustained muscle contraction is often what happens is that both the muscles that we call that agonist and antagonist muscle. So if you want to, for example, bend your elbow, there is a muscle that actually has to contract. This is your bicep to actually bend the elbow. And there's a muscle, the tricep, which is behind, which has to relax for the elbow to actually bend. If they both contract at the same time, this is when you can get dystonia. And dystonia lead to abnormal postures, okay? And it can lead to abnormal movements, the twisting movements like this, and sometimes a tremor. There are very specific characteristics of dystonia. So some people will get dystonia, which we call task specific. So a good example of that is when some pianists, for example, would get dystonia of their fingers only when they play piano, not in other circumstances. One important point is also a lot of patients with dystonia have what we call a sensory trick. The classic sensory trick is for patients that have dystonia of the neck, and they do have a tremor of the neck like this. I'm going to show you a lot of movement disorder today. So they have a tremor of the neck, something like this. If they put their hands on their cheek, then the posture gets better and the tremor stops. The other thing is sometimes it depends on what you're actually doing, so the state of function. So we have kids that have dystonia when they walk forwards, but when you make them walk backwards, then they don't have dystonia anymore. One of the common sensory tricks that we have in kids that have generalized dystonia, which is most kids with leukodystrophies and 4A and HABC, is so if they have their hands stuck like this, if you massage the forearm, most of the time they're going to be able to relax. The other thing is if their hand is clenched, sometimes if you put your finger inside and massage the hand, then the hand will relax. For kids that have a problem, dystonia when they walk, one good sensory trick is to actually a lot of the kids put their hands in their pocket, and that helps them walk without dystonia or with less dystonia. But I recommend not to put the hands in their pocket, because if they fall, they're gonna get hurt. But some of the kids I ask to actually just put their hands on their thigh, so if they fall, they can still try to not getting too hurt. So dystonia is also characterized by where the dystonia is. So if it's only on one body part, we call it focal. If it's two contiguous body parts, let's say the face has dystonia and the neck, we call that segmental. Multifocal dystonia would be, for example, one arm and one leg. And then generalized is when you have the trunk or the back that's involved, and the arms and the legs typically. And that's most of our kids with leukodystrophies. And hemidystonia is one half of the body with dystonia. Whoops. It's important to differentiate dystonia from spasticity, because they're not treated the same way. They're both disorders that increase tone, so make the kids stiffer. But the difference between dystonia and spasticity is what we call velocity dependent. So when we examine your kids, I'm sure that you've noticed we look at the tone like this, but we also do rapid movement. And the rapid movement is actually to get the spasticity out of the exam. Where the problem is different in terms of looking at the brain. So for for spasticity, it's the motor tract. So basically, the right side of the brain makes the left side of the body move. So the tracts that are responsible for that, from the brain to the lower spinal cord, is if they're lesioned, if there's a lesion there or a problem, then you're going to get spasticity. Whereas the dystonia comes from what we call the basal ganglia, which are in the middle of the brain in the oval I just draw here. Spasticity leads to increased tone. Some kids with spasticity do have postures as well, but they're very specific postures, and they don't lead to a tremor or a twisting movements. So this is an example of a child with spasticity. When we hold them behind below the axilla on both sides like this, they often have a scissoring of the legs. Other things that we do on exam to actually differentiate dystonia from spasticity is the reflexes with the hammer. And that's the funniest part of the neurological exam. When they're really brisk, that points towards spasticity. And the kids with spasticity also have what we call upgoing toes. So when your doctor scratch the bottom of the foot of your child and the toes goes up, that's part of the spasticity as well. So in research and mostly, we use some dystonia scales to actually quantify the amount of dystonia and follow this over time to see whether the patients are responding to a treatment. There are different scales. I've listed them there, but the important point is that if you're participating in a natural history study and hopefully in the future to a clinical trial, one of these scales will probably be used, and that takes some time, and it implies doing a video of a very standardized video of the exam, so that other movement disorder person can review them later on and actually score them to see whether or not the score is changing over time. So how do we manage dystonia? There are some easy things to do that do not have side effect. The first is avoiding all medication that block the D2 receptors. If you say that to your doctor, they'll know which medications there are about. Some of them are neuroleptics medication, like the risperidone and Haldol and things like that. And others are medication to help digest, like metoclopramide or Maxiran. And then another very important point is to have the fingernails very short, because a lot of the kids with dystonia tend to clench their fist. And so if they get a wound inside their hands, then it's very hard to make it heal because it's always clenched and it can get infected. Okay. Another very important thing is to take advantage of the sensory tricks. Try to message different part of your child's body when they're stiff, and see whether or not it can help them relax. There are a list of medications or therapies that we can use for dystonia. The first is called Sinemet or carbidopa levodopa. We're not going to talk about it because really this medication is used for a very limited number of indications, and typically not for leukodystrophy patients. There's two next medications, the Artane and the Parsitin, are both medication we call anticholinergic. We'll talk about them a little bit later. And then next is tetrabenazine, and then there's baclofen, there's the benzodiazepine, the Botox or botulinum toxin, and the deep brain stimulation. So we'll talk about these briefly. So the anticholinergic medications are, especially Artane or triaxiphenidil is the most studied drug for dystonia. It's been shown to be very effective for dystonia. The main limiting factor is side effect. But in kids, kids have less side effect than adult patients. So there are some brain side effects. So it can affect attention and memory, and very rarely it can give behavioral problems. And then there are peripheral side effects. So what we call peripheral is the body. So constipation. So when I start a patient on an Artane, I usually start a medication to help them not being constipated. And so as I increase the Artane dose, I also increase the constipation medication. dry mouth, which is often a nice side effect to get for our kids because they often have drooling. And when you increase the doses of artane, you can get the pupils are getting bigger, and so when they go outside, that they get the sun bothers them. So having sunglasses is very helpful. And the last one is urinary retention, which would usually happen when you increase the dose very high. And there, of course, all the lists of side effects are not meant to be complete, but to discuss the most common ones. And then, so the Parsitin I use when the artane has caused problem with attention or memory, because there's less, it's thought to have less brain side effect. There's not that many studies, though, but it's thought to be better for brain side effect. The only reason why we don't prescribe this one all the time, it's because it's very hard to get. So I always tell my parents the patients that are on this to make sure. Sometimes you have to call multiple pharmacies before you actually get the medication. At least that's the case in Canada. So that's why an artane in the vast majority of patients works really, really well without significant side effect. The second medication is tetrabenazine, which is a dopamine depleter. And it's good for what we call hyperkinetic movements. So everything that moves too much. So a kid with dystonia and a lot of movements, a lot of twisting movements or a lot of tremor, tetrabenazine is usually a good medication to use. It has side effects. So one of them is that you can be tired with it. It increases secretion. So sometimes that can be a problem for our patients. And sometimes can be done in combination with botulinum toxin injection in the salivatory gland to reduce the secretion. It can have psychiatric side effects, including depression, but it is reversible when you stop the medication. If you increase the dose fast enough, because it reduces the amount of dopamine, you can get something that look like Parkinson's disease. It's not Parkinson's disease, it's just the medication being too high. If you bring it down, it goes away. And the other thing is it can lead to conduction changes in the heart. So this is something that we would test before we start the medication. And again, it's not an exhaustive list of side effects for this medication. The muscle relaxants are a medication that we use sometimes for patients with dystonia. They're not the most efficient medication. Usually artane is the best, and then tetrabenazine, and then the muscle relaxant. So baclofen is a good example of these drugs. It helps with the dystonic spasm. But it's usually not so effective for the dystonia overall. But since our kids often have dystonia and spasticity, baclofen is often a good choice if you want to treat the spasticity and hit a little bit the dystonia. The main side effect for baclofen is being tired. It can reduce the seizure threshold as well. So some of the kids that have epilepsy can have more seizures with it. So usually I wouldn't start it when the epilepsy is not well controlled. For kids who do respond to baclofen but have too much side effect, being more tired or sleepy, baclofen pump can be an option for if everything else has failed. It's not the best treatment for dystonia, but it can help some kids. The benzodiazepine are usually, as a baclofen, used in conjunction with other medication. There are two main medications that are used in that group, the diazepam and the clonazepam. I tend to avoid clonazepam because it increases and thickens secretion. So the kids that have trouble swallowing, it can make that worse. The diazepam does that a little bit less. It's not very efficacious for dystonia, but it can help if you add it. I see some parents like making faces because perhaps your kids are clonazepam. Medicine is like being a cook sometimes. We all have our favorite. Like I often say to the parents, treating epilepsy or treating a movement disorder is like making an omelette. Some cook like to put mushroom in an omelet, and others don't. So I'm giving you my omelet recipes. It doesn't mean that, and I would certainly not want you to stop any medication that your children are on because of what I said today. Every child is different, and your physician should be the person you discuss it before you do anything. So the side effects for benzodiazepine are being tired, so drowsiness. It can, if you increase the doses a lot and you're not used to it, like sudden increase in doses can lead to problem with breathing, and of course, it can lead to addiction. So if you want to reduce a medication like a benzodiazepine, you don't want to stop it right away. You really want to wean it very slowly. Botulinum toxin is the Botox that everybody knows for the wrinkles. It can be a good choice for focal dystonia. So someone who only has neck dystonia, it's the best treatment because you avoid all of the other side effects for the body or the brain. But you have to repeat the injection every 3 to 4 months. For patients with generalized dystonia, which is our patients with leukodystrophies, sometimes if a specific muscle group is problematic, you can do the Botox injection, and it can be very helpful. So, for example, if you have like foot dystonia on one side and the toes are crooked on top of the other, and there's a lot of pain, if you have a good dystonia Botox injector, they can inject the foot and make the toes relax for a little bit. So deep brain stimulation is a little bit like the baclofen pump, something that we would use for like a last resort for severe dystonia. Basically, you put wires into the basal ganglia, the middle part of the brain. You have a pacemaker in the chest, and you stimulate the basal ganglia. You have to program it. You program it externally, and you have to change the battery every few years. It is a very good alternative for certain types of dystonia, what we call the primary dystonias. It's not as good for all the secondary dystonias, including the leukodystrophies. That's why I'm saying it's more of a last resort, a little bit like the baclofen pump. It hasn't been studied, as far as I know, in HABC. And then all the secondary causes haven't been studied as well, but people agree that it's certainly not as effective as it is for the primary dystonia. And the effects are very variable from one individual to another. I just want to put this paper on. This is a manuscript we wrote not so long ago. We updated not so long ago on how to care for patients with leukodystrophies. There's a section of movement disorder that your physicians can have a look at. So I collaborate with Dr. Van der Veer on several studies on leukodystrophies, including HABC. My primary focus is hypomyelination and 4-H, so we couldn't do that without the patients and their families, and with all the collaborators and the member of my team. And this is my funding for my lab. Thank you.